Yeah, I definitely, frequently, always actually tell the patient, your nose will not be perfect, period, end of story. If you're looking for perfection, you're not going to find it. What we can offer you, and I'd say what any surgeon can offer you, is an improvement in A, B, C, and D, whatever elements you may want to achieve.
Ladies and gentlemen, welcome to another episode of the Rhinoplasty podcast with me, Dr. Cameron Mcintosh. We're in Nice at the Preservation Rhinoplasty meeting. And I've managed to track down a guy I've been on to track down for quite a while. Oren Friedman, welcome, man.
Hey, thank you. Great to be here with you. I've been following you for quite a while and finally feel honored that you brought me on.
No, it's awesome, man. I mean, I remember us doing, just when COVID hit, we were doing with Brian Wong, a whole lot of these online meetings, etc. Now we can actually speak in person.
It's great to have that behind us.
So now tell the listeners, where do you come from?
Well, I'm originally from New York City. And when I was 15, my family moved to Philadelphia. And I basically stayed in Philadelphia through high school, college, medical school, residency, until I finally spread my wings and headed out to Portland, Oregon, where I did my fellowship in facial plastics. Yeah. And then that was with Tom Wong and Ted Cook.
Yes.
And just following that, got my first job at the Mayo Clinic in Rochester, Minnesota. And that's where I cut my teeth in rhinoplasty.
And you're still there?
Now I've moved, after 8 years there, I moved on to University of Pennsylvania, back to Philadelphia. Oh, wow. Where my wife and her whole family are from and where my family is from. Yeah. So we had 2 kids, and then we had our 3rd kid on the way. And we decided for schooling and for family, we had to move back.
Absolutely.
Actually, we went out to Mayo thinking we'd be there for 3 years, and we loved it and ended up staying for a lot longer.
Wow. But, I know, you've actually just had a lovely little romantic holiday with your wife, left your kids behind, eh?
Yes. So my wife may kill me for saying this, but she just turned 50, and so...
I met her, there's no ways, really?
You wouldn't think that.
I am impressed,
Yes.
Wow.
Nothing to do with my plastic surgery skills. It's all natural.
Yeah, no, absolutely. Yeah.
So we came about a week ago and spent some time getting to see Paris and some of the wine country, and then arrived here in Nice for the course.
That's fantastic.
Yeah, it was great.
Yeah, and we've had quite a busy day today. I mean, we were both lecturing this morning and then moderating the surgeries this afternoon.
Yeah, it's been a long day.
And now we're smashing out a podcast.
Well, you're amazing.
That's cool, man. So, okay, let's just climb straight into this.
Yeah.
Kind of almost controversially, there has been a slow uptake of teaching preservation in the States over the last few years. Do you agree with that or not?
What do you mean by slow uptake of teaching?
Compared to the Europeans.
Yeah.
It's like been a very hot topic for a few years, and it appears that the fellowship directors over in the States aren't as necessarily proactive of teaching the preservation techniques than they're doing structural techniques.
Right. Well, I think that people like what's tried and true and tested. Yeah. And what a lot of people don't realize is actually, for example, the coddle technique is tried and true and tested. It's been used for decades, and in certain pockets of the world, it's been the primary method of rhinoplasty. Yeah. For example, our friends in Mexico City, and throughout Mexico, grew up doing preservation rhinoplasty, but it was called the coddle technique. Yeah. And they've been at our courses ever since I was a fellow in Portland. They'd come to my courses at Mayo Clinic, and they've been to my course in Penn. And
because they want to come and learn structural.
No,
they've grown up doing this stuff.
The hilarious thing is, for years, they would come to our courses and speak about their technique, which is the coddle technique, actually similar to how people responded to Yves Saban throughout decades of his career.
Yes.
They'd hear what was being said and not really understand the concept or not want to understand it, and write it off as a technique that wasn't worthy. You know?
So one of your talks this morning, I found it fascinating where you were speaking about how there's been this divergence. Maybe you want to tell the listeners a bit about that from like the preservation structural side from decades ago. Yeah. Where did it all start?
Yeah. Well, it's interesting to think about it and to think about the evolution as you're driving at. So Jacques Joseph was a father of rhinoplasty, considered by many to be the father of rhinoplasty. Lived in early 1900s was when he was practicing until 1934 when he passed away. And his technique for reduction of the dorsum, he got a lot of his experience during World War I.
Yes.
When he was involved in trauma surgery, worked at Charité Hospital in Berlin.
Yeah.
And he developed a tremendous amount of experience there and was involved in rhinoplasty surgery. I think doing a lot of ethnic rhinoplasty. He was Jewish. He was the son of a rabbi.
Oh, yes.
And I think he managed many Jewish noses that had have a reputation for being sizable.
Yes. Okay.
And but he approached the dorsum from above. And simultaneously, Maurice Cottle, actually another Jewish surgeon from Chicago, in 1954, developed or promoted what became known as the Cottle technique. He was not the first to do such a technique, but it basically involved removing the bridge of the nose by taking the feet out from under the dorsum.
Yes.
And so Cottle developed a following of his own. But I think what really happened was certain charismatic surgeons seemed to draw a following. Yeah. We see that throughout history. Yeah. We see that today. And Gene Tardy, for example, Gene Tardy was really a very charismatic, very elegant surgeon, very outstanding surgeon. And he and others took on the Joseph technique as their primary method. And Dean Toriumi was from that school, and then most of America and then most of the world became of that school. Yeah. But again, there were always pockets of Cottle devotees.
Yes.
In fact, trainees from the same programs often diverged themselves and became students of one versus the other.
Yes.
With a lot of conflict and a lot of, on stage, for example, at courses, there was a lot of argument about what technique. And so surgeons like Ignacio Tasca in Italy have been very loyal Cottleists for their entire careers. Yves Saban's technique is similar, somewhat different, but similar in concept of taking the feet out from under the dorsum in order to bring down the dorsum. Yeah. And now many very popular surgeons have taken on the preservation technique.
Yes.
The thing to realize is it shouldn't be, just like the argument between endonasal and external, it's not one or the other.
100%.
Yeah. So that's what we have to keep in mind.
Yeah. As
good surgeons and surgeons to all different people and noses that come to see us, we need to have in our armamentarium all the different techniques.
I can't agree with you more.
Yeah.
Okay, changing track a bit. You're very involved with organizing the meetings in America. So podcast goes all over the world. If people want to come and attend the meetings, can you try and break it down as to how it works? If you want to come to the States, when are the meetings, etc.?
To come as attendees at meetings in the States, well, as you know, the American Academy of Facial Plastic and Reconstructive Surgery is our American Academy devoted to our cause of advancing facial plastic surgery. And our primary mission is in education.
Absolutely.
So certainly our academy has led the world for decades in education. Yeah. We love international attendees at our meetings. Our meetings are multiple times throughout the year. We've got our fall meeting, which is generally in September, October. And we've got our spring meetings actually, and they're evolving. So for example, coming up in April, we've got a great aging face and rhinoplasty meeting in Orlando, Florida.
Okay.
That's been the site of some excellent courses in the past. And then fall meeting coming up after that. Just reach out. I mean, we've got it on the websites. We've got many active academy members who you can reach out specifically. If a person wants to present a topic, we've got poster presentation options. We've got podium lectures. And any innovative techniques or reviews would be considered for presentation, and we'd love to consider that.
Yeah, I mean, the AAFPRS has had a massive influence on my career. I mean, I sat the board exams in Washington. We now, for the first time, we're wrapping up our first year of a fellow who is under the umbrella. And, I think one of my kind of, I don't know, challenges to the listeners is don't necessarily go and attend a meeting, go and do a presentation.
Yeah.
You know, I think you learn so much more by actually having the guts to stand up and speak in front of people.
Yeah.
Well,
yeah, I couldn't agree more. And your experience parallels mine and so many others. I mean, and it's not only the American meetings, just as you asked about the American Academy meeting, but any meeting that I go to, there's not a single lecture that I sit through in any meeting where I'm not learning and taking notes.
But Oren, that to me it is so interesting to see that, because we've got this really kind of cool family of rhinoplasty surgeons.
Yeah.
But like under the surface, each guy wants to learn.
Yeah.
And you can see, it's fascinating. Even today, sitting in theater there, I mean, I wasn't on your guy's side, but I was in the OR and watching like old Bart checking Valerio and seeing every movement of his hand.
Yeah.
Fascinating.
I think, as the old dictum goes, the more you know, the more you realize you don't know.
Yeah.
And then there's so many, just as you said, so many nuances that, just when you think you have the operation down, you might have a bad result, or you might have something you're disappointed with. Probably often we have results that we wish we could have done slightly better on.
Yes.
Yeah.
Okay, so like you're a really friendly, happy guy, always seeing the positive, but surely you need to, I want to talk to you about that one patient a year who messes your life up for you. And you just think, what am I doing? I want to go and live by the beach, or in my case, I want to go and be a farmer, How do you deal with those stresses?
You want to be a former what? No, I know. Yeah, look, every field I'm sure that we would undertake, any profession and any job has its stressors. And in medicine, of course, every field the same. And as you obviously know, for us, the challenge is we can't hide behind anything. The nose is front and center. So the foundation is for us to develop techniques, learn techniques that are safe and effective for our patients to embrace. But of course, the complicating factor is, number one, the nose is right there in the center.
Yeah.
As is the face itself. We can't hide it anywhere. Yeah. And so then there's the psychological aspect.
Yes.
And trying to come to an agreement with the patient about what they want is before surgery is perhaps the most important aspect of success in any of the operations that we do. And balancing and matching the patient's expectations with the realities of what we can deliver to that patient are really the art of this science.
Okay, so 2 more questions on this now. How many rejections are you giving yourself? So what I'm meaning, a patient who is interested to come to you for a rhinoplasty, what kind of percentage of patients ends up actually being operated by you?
It's a tough one to answer. Functional patient, cosmetic patient, what is a patient?
I'm talking cosmetic.
Yeah,
a functional patient, it's highly unlikely you can't fix the functional problem.
Right.
I'm saying with the cosmetic patients.
Yeah, to be honest, I would say maybe 10% of patients are that may
you wouldn't operate on.
Yeah, maybe that.
Okay, so then this brings me to the next question. And I think this question is more aimed at the doctors who are listening on the podcast rather than patients.
Yeah.
How do you break the bad news to the patient?
It's very challenging at times.
Yeah.
You're trying to get through a long day in the office with patients. It's often much quicker to just say, okay, fine, let's do it, and pick a date. And
I agree with you, but it can come back to bite you.
Oh, definitely.
Yeah.
Definitely. And so then you just have to remember that one patient a year that you're thinking, I want to go back and be a farmer and not do this anymore. Yeah.
I'm finding I'm trying to under-promise even more and more and more.
Yeah.
Because it's so much better to have a patient come back and say, oh, wow, than someone who moans.
Yeah. Yeah, I definitely, frequently, always actually tell the patient, your nose will not be perfect, period, end of story. If you're looking for perfection, you're not going to find it. What we can offer you, and I'd say what any surgeon can offer you, is an improvement in A, B, C, and D, whatever elements you may want to achieve. But the worst challenges that I've seen are patients who you think you have a good understanding of what they want beforehand, and you're happy with the outcome after surgery. You've done a really nice job. And they're not happy. And it rarely occurs, but when it does, I found that it relates to what I thought I understood the patient wanted out of the operation is not what they envisioned. And perhaps in some cases, the patient has some underlying psychological issue. We know that depression, anxiety is prevalent in our patient population. Above 30%, it's been said, have some of that. The extreme body dysmorphic disorder is present among some of our patients. And we really have to have a keen eye and not have not be so eager to do surgery just to fill our books. Yeah,
absolutely. But then on the flip side, patient comes back and they're super delighted with the outcome, and you just think to yourself, oh, please, can I do some more operating?
Right. Yeah. Finishing that thought and also the previous question, I actually think, what gives us pleasure in what we do is the feedback that we get from the patients. We are aiming to please.
Yes.
I think those of us who love our job in rhinoplasty and facial plastic surgery, it's because we want to get that positive feedback.
Yes.
And it's because we love our patients.
Yes.
Really.
Absolutely.
Yeah, we want to. And so, again, it goes back to why do we take that time? It's not just to avoid the minefield and the pitfalls, but we're taking our time because we actually want to give the patient what they want as a result. We want to deliver for them what they've been dreaming of for all the time that it took for them to get to that moment when they're sitting before you asking for surgery.
Okay, so the last topic, I'm kind of, without having pre-warned you about this, I'm just interested to know Dr. Oren Friedman's thoughts on columella strut versus septal extension graft, and what, in your mind, works for you and why. I think it's kind of a topic that was spoken about a few years ago, but why I asked that is I was in Dallas last week in a visit with Spencer Cochran, and I'd been leaning towards septal extension grafts over the last few years. And then seeing what he was doing, seeing what Valeria was doing today, I was like, very interesting.
Well, I mean, I think, again, it comes down to this whole idea of structural versus preservation, actually. Of course, septal extension graft is the number one most powerful structural support we can give to the tip of the nose.
Yes.
But actually, you can wed those two. So what Valerio did today, essentially the caudal technique, when you're pulling the caudal septum anteriorly, you're creating more opportunities for a septal extension graft. Because then the distance between the medial crura to the caudal septum is minimized as you're pulling that caudal septum outward in order to bring the dorsum down. But at the same time, you don't need to do such a strong caudal septal extension graft as we're accustomed to in the structural techniques. So it's sort of a soft septal extension graft, a soft tongue-in groove that you can do without actually fixing the medial crura to the caudal septum, to the new construct of the caudal septum, but dissecting between the medial crura to just let it rest in that area. And so that actually adds beautiful tip support, even without a columellar strut graft. So you're not actually fixing the medial crural cartilage to the caudal septum necessarily, but you're overlapping the membranous septum. You're making smaller the mucosal segment of the, or the soft tissue segment of the membranous septum, so that there's effectively much better tip support.
And what are you doing generally? Because we spoke about some of the, I mean, it's brilliant, that answer. Love it. But on the table, what are you doing?
That's what I'm doing most of the time. I love to laminate the septum to strengthen the septum both along the dorsal and the caudal aspect. And then I love to relax the medial crura onto the new construct of the caudal septum. And I think that it's really natural, doesn't have that issue of you can't move the tip relative to the rest of the nose. I believe right now we're overdoing our tip. That's my personal aesthetic, is that we're overdoing the tip management,
Yes.
even in preservation.
Yeah.
I love endonasal for preservation. I would say preservation for me is only endonasal. I do not believe in external preservation. I think those two concepts are opposite.
Love it.
External rhinoplasty does not go with preservation rhinoplasty.
Yes. Jeez.
What do you think about
That's
that?
a knockout punch, man. I was thinking, yes, I want to ask you one more question, but I think that's brilliant.
Yeah.
Yeah. Wow, very interesting. Okay, last question then. What are some of your hobbies, stuff you do when you're not doing this?
Oh, man. I mean, I admire your hobby. I don't know if you're still doing it, but it only recently became known to me that you're an Olympic kayaker.
Yeah.
Unbelievable.
Yeah, that wasn't a hobby, that was a job,
That was a job, yeah. I
Yeah.
bet.
Now my hobby is long distance shooting, eh?
Oh,
It is so challenging trying to shoot at 1,000 yards.
amazing.
And the amount of preparation that goes into it, it's like
Learning how to breathe.
kind of the rhinoplasty, but without the patient problems.
Right. Just the target's problems. Actually, I like to kayak. We do that as a family very often, but not whitewater kayaking, just lake water typically.
No, well, listen, it might sound a bit, it's a podcast, I can say it. Friend of mine, he crazy kayaker. We grew up together. He went into really crazy kayaking. I was doing slalom whitewater. Had a bumper sticker on the back of his truck. He said he'd rather eat cotch than paddle flat water.
Well,
That's like some nuts, though.
I'm hoping one day you teach me that song.
love to.
That looks so awesome. Yeah. So awesome.
Awesome. All right, listen, thank you so much.
Hey,
eh?
thank you.
It's lovely to chat, and it's like cool to kind of delve deep into some of these subjects. Yeah. So, guys, listen, thank you so much for listening again. Come back next week and just keep listening. I think it's fantastic to learn from these guys, and I really hope you guys will come to these meetings as well. So thank you.
And thanks, Cameron, for all that you do for our specialty, because it's really amazing the educational value that you bring single-handedly, really, and with your team to advance education of our specialty, which ultimately obviously benefits the patients. Thank you for all you do.
Awesome, man. Thanks. Eh?
Thanks. Yep.
For those of you who are only listening to this on a podcast platform, please try and reach out and get onto YouTube, because on our YouTube channel, we've got some really cool clips where I interview the guests.